Sometimes the best way to understand something is to step away from the topic and look at it through someone else's eyes. I'm Andy Reynolds. For a fresh look at what data interoperability means and why it matters, I spoke with a longtime consultant to NCQA and other organizations, John Demore. John, welcome to Quality Matters.
Andy, thank you so much.
I'm intrigued by your bio. You've been in health IT for more than 20 years. You are an informaticist who has worked with a variety of technologies in diverse settings. And how do you summarize where you have been and where you're headed in health IT?
I'm aware of many hats. I've spent a lot of time thinking about the ecosystem for healthcare data and how it comes together. I had a startup that processed data from health information exchanges and health insurers, normalizing and improving data quality. Got a master's in informatics. I'm a published researcher and I love this field. I teach informatics and standards and how to use data to improve care. I work most on standards and making information more fit for use across the ecosystem.
With all the things you've done and the many places you've been, your LinkedIn profile identifies you simply as a healthcare interoperability expert. How or why does everything come down to interoperability for you?
It really is a personal story. I was at a big healthcare system working across 12 hospitals to bring together reporting for executives. We said we can have a machine automatically interpret the results to say, hey, is this patient on an antibiotic that will treat their infection? We could close that gap, bringing down the time to treatment. We launched that app and it ran for a decade and saved lives for our healthcare system. But we tried to say, hey, can we take this app to other healthcare systems? We went to our EHR provider and said, could we give this to your other clients? We want to give it away. And they said, oh no, John, that would never work. Data you use for your app are so different than the data other people use. There was no scaling. If another hospital system wanted to do what we did, they'd have to rewrite the app from scratch. And that was just unacceptable. That was a call to action. I said, we need to make our learning healthcare system better and one that can scale. So when you get the good idea, that can flow out to hospitals, other healthcare settings, other physicians. That led me into informatics, into interoperability, because that's the critical component to make this possible.
You say interoperability is the critical component, but interoperability is a big idea with many implications and even different definitions. So how do you take this sprawling topic of interoperability and make it smaller and manageable?
I focus on clinical data interoperability because it's the problem we haven't solved yet. How can we take the information, make it flow seamlessly, efficiently to the next providers of care, to patients, and unlock that potential for a learning healthcare system? I'm an editor on multiple standards, and I believe those are going to be essential to the improvements to care that we want to see. But I also don't think that interoperability is an end into itself. It's a tool. It's a tool to be able to deliver higher quality care and also care that's just much more efficient, that reduces administrative burden in the healthcare system. So my specialty is in making that tool work well.
So it sounds like your work is all about interoperability, but you're thinking of interoperability as only a means to something more. Unpack that for me, please.
We don't really want interoperability for its own sake. Free flow of information, if it's never used by the destinations, isn't useful. It doesn't improve care. It doesn't bring down costs. When you go to Home Depot or Lowe's and buy a power drill, what are you really trying to buy? You want holes in the wall. Interoperability is the tool or the power drill that delivers the holes that we want. And the holes are better, more efficient care that reduces costs. I mean, can we envision a future where healthcare costs go down year over year? It sounds almost impossible. It sounds like a fantasy land. I think it's going to be within reach within the next 20 years.
That sounds great. How do we get there?
We have the highways for this information to flow, but we need to work on the business incentives. One of the things I'm a big advocate for is not watching what people say, but watch where the money flows and how that makes an impact. Getting the right information into the right systems is critical because we can't manage things that we can't measure. Improving healthcare quality, improving information flow, having patients be able to access their own information. These are not partisan issues. Republican, Democrat, it doesn't really matter. Everybody knows that we're living in a suboptimal world and we want to be able to do better. I go back to that adage, follow the money, things that save meaningful dollars or affect meaningful portions of reimbursement will get done. If you can't find the economic incentives that align with those things, they're probably not going to happen or they're not going to happen quickly.
And on that note of economic incentives, you pointed out that Support for these kinds of reforms is bipartisan or indeed nonpartisan, but one person's waste or inefficiency is another person's margin. So it is partisan in the sense that a lot of people make a lot of money on the way things are. What do we do about that?
You're right. One person's cost is another person's revenue. I loved when I started learning about the health plan market. They talk about their costs and medical loss ratios. The thing about that, medical loss is actually money is spent to care for the patients. It's the dollars that go to hospitals and physicians. It's not a loss from the patient's perspective, but from an insurance perspective, that's a loss. That's a claim. But I see not just bipartisan, but nonpartisan occurrence. They have a direct feedback loop on interoperability. This idea that, hey, clinicians, healthcare systems, organizations that deliver higher care quality are going to receive more dollars. You can improve your performance under value-based purchasing two ways. One is to actually alter care. I'm going to do something I wasn't doing before. The other way is to improve data collection. And that is all about interoperability. It's expensive to change the way the care is delivered, and it's much cheaper to improve data collection. What I want to see is that data collection becomes so easy that that's no longer a meaningful portion of measuring quality. Essentially, everybody has access to all the data, and all the data is usable for all the right purposes in measuring care quality. And so the only thing that will determine who gets more money or who gets less money is who's delivering the best care.
Let me share something with you, and I'd like your reaction to it. We'll link in the show notes to a recent NCQA blog titled Improving HEDIS Data Quality in a Digital World. We say in that blog that the United States has invested a lot of resources in building pipelines for transmission of electronic clinical data, but we're still evaluating the quality of the data flowing through the pipes. This distinction between good pipes, bad water, good pipes, bad data jumped out at me. Walk through this discrepancy, please, between quality of care versus quality of data about care.
Yeah, this is the essence of why we work on interoperability. Let me drill into that. Good pipes, bad data, or good pipes, bad water. If we have feedback loops, we can be able to always make improvements. Early on in billing information, if you didn't send the right information, there's a very distinct feedback loop, which is your bill didn't get paid. You put down the wrong date of birth from somebody's insurance information, the health insurer just rejects that, says that's bad data, and you're not going to get paid till you fix it. In the clinical data world, it's a little bit different. We have a lot of pipes. We have a lot of water in those pipes for interoperability, but is that high data quality? The feedback loop is, hey, you sent me this patient's record, but it had no lab information. You get a complaint from the receiving physician. I didn't get what you need to send me. The problem is quality in that context of care continuity is different than data quality in the context of quality measurement. Now, the data quality of something that had a feedback loop to make sure the right information was flowing doesn't have the right feedback. We need to create another feedback loop to improve that data quality for the purposes of quality measurement. So what is the ultimate feedback loop in a capitalist society? It's money. And we're beginning to see that feedback loop. What is the money associated with care quality in the United States? HEDIS is used in Medicare Advantage, but also other plans measure care quality. And those health insurers are receiving bonuses or shared savings as a part of being able to deliver higher quality. So part of getting higher quality means you need to have higher quality data inputs. We are beginning to see the seeds for improving the data quality for quality measurement in those pipes. The pipes really have only come on in the past 5 years. I'd love to say that we could fix the water quality really quickly, but it's going to take time. One thing that's lacking, Andy, is we don't have authorities measuring the water quality yet. NCQA does a great job broadcasting how the nation is doing around HEDIS measures, but we don't measure the data quality inputs to all those things. And until you start measuring that, which is part of NCQA's next generation of programs, and we might not see as quick progress as we want to in some of those domains.
I spoke to someone at NCQA who's building that next generation of data quality programs.
Hi, my name's Ben Hanley. I'm Director of Product Management at NCQA.
Ben, our existing methods to assure the validity and reliability of HEDIS results include the HEDIS audit and the data aggregator validation program. We'll link to those programs in the show notes, but you're working on something that will go even farther to assure data are valid and reliable. What can you tell us about all of that, please?
We're looking to evolve data quality assessments that may not only improve our understanding of data quality from various data sources, but also shift the effort on primary source verification that is used currently. We see moving more towards automated data quality assessments and away from what is often a very manual process with primary source verification. Our hope is that by introducing new tools that automate a data quality assessment, we'll have a better understanding of data quality, and that will lead to efficiencies and ensure data used for HEDIS is trusted and reliable.
I've heard NCQA's aspirations with regard to data quality likened to certifying organic produce. Can you explain that comparison to me, please? What does NCQA have to do with organic apples?
When you're in the store, it's difficult to tell whether an apple is organic or non-organic. It's all based on trust when you're looking at those seals and those logos or the messaging from the grocer. So we're trying to build a trusted process and be open about it, how we measure and how we think about data quality, the different dimensions we use to define data quality, so that there is a process behind it, just like there was a process that certifies organic produce, builds trust with the customers. So people can understand that behind that, there's been an awful lot of thought and analysis to help define, analyze, and assess data quality.
I think of organic anything as being more expensive than conventional alternatives. Is that the case here? Will getting confirmed clean data cost more?
We believe automating data quality analysis is going to reduce the cost, and it's what we're working through to make sure we deliver. NCQA is committed to making our programs more efficient and customer friendly when it comes to ensuring trust in our programs and the data behind them. As the entire industry becomes increasingly digital and data is more important every day, we need to focus our idea of quality, not just on clinical quality the way we have traditionally, but on data quality as well. It just makes sense for the environment that we're all working towards.
John, you speak to many audiences about interoperability topics. What do you find are the most common myths or misconceptions that you have to talk people out of? What is the most common correction you have to make to their mental model?
People believe there are just technical things that markedly improve our data quality. One is FHIR, Fast Healthcare Interoperability Resources. People believe that will fix their data quality issues and be this panacea for interoperability. I love FHIR. It advances us to a web modern way of exchanging information. It won't solve most of our problems, and it certainly won't solve our data quality problems. Data quality can be high in FHIR or poor data in FHIR. FHIR is just the medium. Just like we can all speak English, FHIR is the syntax. It gives us the words. But just because we can all speak English doesn't mean I can write great poetry. So the first thing I like to clean up is don't look for a technical standard to fix your business problems. To get to semantic interoperability, data being understood from the source system to the receiver system, it requires more than a technical framework. It requires work, processes, trust within the ecosystem. The other myth that I can dispel is the thing people jump to when they hear there's going to be work and there's going to be cost. They just say, well, maybe I can just skip this. John, we're just going to use natural language processing. We're just going to use an LLM. And these new technologies will just do magic to improve data quality. And I am really excited about both of those technologies. FHIR is a great advancement, but you can't skip the hard work. If you don't go to the gym, you don't get the muscles. If you don't put in the hard work, you're not going to have high enough data quality to do all these things that we want to do. So a lot of my dispelling is telling people that you think that this is a technical issue and that you're going to have a technical solution. Actually, this is a political challenge, a process challenge, a governance challenge. People don't like to hear that because they know there's work associated with those things. And if they could flip the switch, they'd like to do so.
I'm curious about causality, or what leads to what. Should people want interoperability so we can get better quality measurement and better quality? Or is there another way of thinking about interoperability and healthcare quality?
In all honesty, I see quality measurement as the thing that drives better interoperability. It's the financial incentive to do so.
Okay, so quality measurement driving interoperability, not the other way around. Tell me more about that, please.
These feedback loops are essential. You put poor data quality into a bill, you don't get paid. That's your feedback loop. If I put poor data into the clinical record, what is my feedback loop? Well, bad performance and quality measures is your feedback loop. And then that gets tied to bonuses. Quality measurement would be really easy if our care was done by one physician at one organization. But here, quality is a team sport. And how do you do measurements across many different providers that are caring for a patient, care teams that might be 2, 5, 10, or sometimes more clinicians. But I do believe that the measurement of care quality and the nonpartisan agreement that we want to move to a system that's based on quality will continue to push forward interoperability. Frankly, it has. I mean, the reason we had the pipes this past decade is we knew we had to build that, and we put in the right incentives to do so. Now we have to move the incentives to not pipe building anymore. It needs to be improving the quality of the data in those pipes or being able to measure that water quality.
I know a lot of people who've worked in quality for a long time would be proud if we end up being the catalyst or an early driver of interoperability, because interoperability is not only about quality and quality measurement. Interoperability would help other parts of healthcare. I hear you saying if we do our job right in the quality world when it comes to data quality, we would be helping beyond our own corner of healthcare. Am I hearing you right?
Let me give the shortest response I can, an emphatic yes. That is exactly the role for NCQA and for quality measurement generally. That is an essential thing, and it will pay dividends well beyond just the programs that are implemented to be able to improve data quality.
I've never heard it framed quite that way, John. I like the picture you're painting. I think that's an inspiring and energizing note on which to end. John D'Amore, thank you for joining us on Quality Matters. We really appreciate your time. This has been a fun conversation.
Andy, thank you so much. I really appreciate speaking with you today, but also the important work that NCQA does regularly to be able to improve healthcare.
You can learn about these and other quality topics at NCQA's largest conference of 2025, the Health Innovation Summit, October 13th to 15th in San Diego. Learn more at ncqa.org/events. Thank you for listening to Quality Matters. You can always learn more at ncqa.org, and be sure to subscribe to Quality Matters wherever you get your podcasts.